Good morning, everyone. Thank you for joining us for this R25 seminar that's being hosted by the Department of Otolaryngology, Head and Neck Surgery here at the University of Colorado Anschutz campus. Today, we are so pleased and honored to have Dr. Tal Marom join us for this seminar. He is a senior lecturer, which is equivalent to an associate professor of the Otolaryngology, Head and Neck Surgery Department of the Ben Gurion University of the Negev, Beersheba, Israel. He is also the head of the Pediatric Otolaryngology Division in Samson Asuta Ashdod Hospital. He did his otolaryngology residency in Tel Aviv University and his research fellowship with Professor Tasi Chonmaitri, who's joining us today. They are from University of Texas Medical Branch Galveston, and they used to work on upper airway viruses. Tal is on the editorial board of multiple ENT and pediatrics journals and is the Israeli liaison to the European Society of Pediatric Otolaryngology. He is also the chair of the research committee and a board member of the International Society for Otitis Media, and proudly a mentor of the Commend Network for Otitis Media Researchers. He's mentored more than 20 MDs, residents, fellows, PhDs, has multiple awards for his scientific work and an Excellence in Clinical Teaching Award from his home university, more than 130 publications, almost 300 lectures in the international circuit. I don't know how you do that. Multiple grants on otitis media, and simply loves to learn and teach. I'm so proud to have him as my friend. Thanks, Doc, for coming. Please go ahead and give your talk.
All right. Good morning, everybody. Thank you for the invitation. So I came here to Denver, for other business, and I just, emailed Reggie and said, "Hey, why don't we just hang up, together?" And she said, "Well, if you want to meet me, you have to come and give a lecture." So that was the deal. So I'm Tal Marom. So I'm a clinician. I'm an otolaryngologist, as you say, and I come from the University of the Bangor University of the Negev, which is probably the fourth biggest university in Israel. This is the hospital where I work for. It was inaugurated in 2017, so it's actually the newest hospital. It's not as big as yours, okay? And we serve a population of about like 250, 300,000 people. Okay. So the title of my work is Otitis Media 2026. Okay, it sounds very banal. Okay, what's new with that? And I'll show you. And where are we now? Okay, I do have to declare conflict of interest, so I receive royalty from UpToDate.com. Okay, and I use AI tools, okay, to prepare just figures, okay, and diagrams for this presentation. And I take full responsibility for the accuracy and integrity of all content presented. So that was my COI. Okay, so this is me. Okay, so I started my journey. This is where I trained. Okay, this is the Edith Wolfson Medical Center. It's in the southern suburbs of Tel Aviv. Tel Aviv is the biggest city in Israel. The city itself, it has like 400,000 people, but in the bigger area, okay, it's about like 1.5 million inhabitants. As Reggie said, so after I finished my residency, I went to do my post-training fellowship at the UTMB. This is actually the first medical school in the southwestern part of the United States. So Galveston is right here. This is the island of Galveston, okay? And you have the I-45, and this is towards Houston. Hot and humid. And I was actually a trainee. I was trained by Dr. Tasni Chalmatri, who's with us today, and I am honored to be her student. As I said, I work now in the city of Ashdod. I live not about 20 miles from the hospital. So this is me. This is my family. That's my wife, Rachel. I have three kids, 18, 21, and 25. She just graduated medical school in Jerusalem, and she wants to become pediatric surgeon. So that's okay with me, of course. So my journey, as Reggie asked me to talk about my journey in the otitis media business. Okay, so I started ENT, head and neck surgery residency in 2005. I was interested in pediatrics subspecialty, and since we do not have any fellowship programs in Israel, so I started to negotiate with mentors okay, but the negotiations were not very fruitful. And then I went to ESPO. I'm not sure if you know about it, but I really highly recommend you. ESPO is the European Society of Pediatric Otolaryngology. It convenes every 2 years in Europe. Okay, at that time in 2010, it was in Pamplona in Spain. Next year, if you want to come and join us, it's going to be in Prague in the Czech Republic. So, and then I met this lady. Her name is Anne Schilder. She's from the Netherlands. Okay, and she said, you know what? I want you to come to the Netherlands, but you have to speak Dutch. I told her, well, and everybody in the Netherlands, okay, to speak English, but said you have to write in the medical charts, right, in Dutch, okay? That's the official language there. Are you 100% sure that you'll be able to learn Dutch by the time you arrive? I had to, I lied to myself. I said yes, but I had to be honest, okay? And I said no, it's very difficult, okay? It's similar to English, okay? But sometimes they have just like words like I think like 20 letters, okay? You cannot even articulate. But this is how I got connected to Dr. Tometry in Texas, and yeah, okay. And this is pictures of us from the time in Texas. Okay, this is where the ear, nose, and throat group. Okay, this is like the whole group, and this is Dr. Tometry. Okay, when she was visiting with me in Israel, maybe 2 years after I left there. So I am honored to be her student. So the ISO meetings, ISO stands for International Society of Otitis Media. Okay, so I attended all of them since 2013. The next one's going to be in the Philippines, so you are welcome. We try to host the two meetings in Tel Aviv. Okay, the 2021 was actually we could not do it because of COVID, and 2025 because of the October 10th, October 7th events that we had. So it it moved at that time to Philly, okay, and next time it's going to be in the Philippines, and it's a close society. It's a very small society. We get to know everybody, okay, and it I think it's a group of very skilled and high quality researchers, okay, doing otitis media research. Now back to our talk. So that was about me and about where I come from and what I do for a living. So if you click Otitis Media in PubMed. Okay, this is from about 2 weeks ago. Okay, there are more, and you restrict your search for humans and English literature, you get more than 22,000 results. Okay, so this is it's still a very popular topic that researchers are interested to. The focus of this talk would be AOM, okay? You all know about what's AOM. I don't have to explain to you. It's still the most common infectious disease of childhood. It's the number one cause for antibiotic prescription in children. Fourth leading visit for pediatrician visits. And when you think about it, we insert more tubes, okay? Then we do a pedectomy, okay? Or correct TOF, the tetralogy of Fallot, okay? Or even repair hernias. Okay, so you all did that surgery, and it's very common. So what's about the burden of otitis media? This is I'll try to show you some data from this country, okay? And as you see, it takes a lot of time, okay, till you analyze. So this is for 2015, almost 11 years ago. And this is like the 10 most common listed reasons for pediatric ED visits by body system. And you see almost 10 million ED visits, okay, of kids, okay? And the number one cause was the respiratory disorders. And when you analyze this bar, about 70% was attributed to otitis media. Now, what about this is the incidence, okay? You look at the numbers differently. This is before and after the introduction of pneumococcal conjugate vaccines, the PCVs, okay? So this data, I'm not sure it's really correct. It's not very accurate. I don't believe you had like in 2 years only 240,000 cases across the US of otitis media. But these are numbers that come from a big database, okay, studies. I'll show you in a bit. Okay, and as you see, even after the introduction of PCV7, PCV13, okay, it's still a huge problem. And is it expensive? Yes. If you hospitalize kid with acute otitis media, it's very seldom. Okay, usually you treat it as an outpatient in the outpatient setting. But if he has like, so for example, mastoiditis, or if it's you have treatment failure, okay, if you need to drain the ear, it's about $15,000. Okay, and if you treat the patient in the outpatient settings, if you require ED or not requiring ED, so here are the numbers. And don't forget about other costs. For example, if the parent does not go to work, okay, so it's the indirect cost. It's a lot of money. So it is still prevalent despite all the efforts trying to restrain the otitis media, and expensive. So the outline of my talk would be about efforts to restrain acute otitis media, new bacteria, new diagnostic tools, and new drugs. Okay, you'll see all of them, okay, coming to the table pretty soon. Okay, some of them are already in use. I won't talk about guidelines and CME activities. You probably have this for the residents, and but I'll talk more about vaccines and the other stuff that I just showed you. So, just in a word, in more than 60 countries, you have guidelines, okay, for AOM diagnosis and management. Okay, most of them call for watchful waiting in most mild, moderate cases. What it means, no antibiotics. Okay, I'm sure you do that here as well as we do. The second arm, okay, trying to reduce acute otitis media is the introduction of pneumococcal conjugate vaccines, the PCV, worldwide, not just here in this country, everywhere. The development of those PCVs was not actually for otitis media. It was for invasive pneumococcal diseases, okay, and meningitis and pneumonia. But the biggest benefit was for acute otitis media, and I'll show you that in a while. What about flu vaccines? I'll talk about it. And this is like the latest development is the introduction of RSV vaccines. Okay, they've been trying to develop them for more than 50 years. Only now they came up, okay, with a potent vaccine. Okay, and I'll show you in a bit. Okay, they try to immunize the mothers while they're still pregnant, and the infants. Okay, we're not sure which one is better. So the Bible is the AAP guidelines, okay, from the diagnosis and management of acute media. Okay, you'll find them. These are the latest version. It came up in 2013. It was published in Pediatrics. Okay, and the bottom line is accurate diagnosis is the key for. You start with this, okay? In Israel, you cannot write in the medical chart AOM question mark, or I'm not sure if it's AOM. No, you can go to court, okay? If the kid had AOM and you said a questionable episode, not good for you. You have to be very accurate with the diagnosis. And how do you make the diagnosis? You're all familiar with those figures, okay? So this is a normal appearing tympanic membrane in A, and this is F. You have a full lunging AOM. You see, so here you have some fluids, okay? Here you see the bubbles, okay? You see here the pus, okay? This is the bulging of the tympanic membrane, and this is just a second before it ruptures. Okay, I don't have to explain to you because you are all in this area. What about the vaccines? So we had a vaccine against the pneumococcal from the 80s. The commercial names are Pneumovax and Prodiax 23. So it was against 23 strains of strep pneumo. The problem was it was not immunogenic enough in kids. Okay, it was not effective in kids less than 2 years. It had no nasal effect on nasal carriage of strep pneumo, the herd immunity effect, and so forth. In 2000, they launched a new generation of a vaccine. Now we call it pneumococcal conjugated vaccine. What's a conjugated? You take some of the epitopes from the strep pneumo and you conjugate them to a diphtheria protein carrier, and that was the game changer. Okay, that changed the whole thing. This vaccine now was very, very immunogenic. Okay, in kids. So they first started it in Northern California, and after they showed that it was effective It was approved for commercial use in the US in 2000, 2002 in Canada, and it was PCV7. Why 7? Because it contained 7 serotypes in the vaccine. At that time, okay, 25 years ago, these 7 serotypes, okay, were responsible for 85, 85% of cases of pneumococcal diseases, 70% of IPD cases in the US, and 65 to 80% in other of IPD cases in other countries. 10 years later, they introduced PCV13. Why 13? Because it has protection against all the serotypes that were in the PCV7 and 6 new. Why was that? Because of a phenomenon that we call serotype replacement. Okay, there are more than 90% of serotypes of the strep pneumo. Once you started immunizing against only 7, other strains will come up. Okay, and these were the strains, okay, that were included in the PCV13. Mind you, like the COVID vaccines, okay, it was approved after non-inferiority studies. What it means, it was as good as PCV7, and the logic was if it has more strains, okay, so we'll start vaccinate with PCV13, okay, and stop using PCV7. Okay, it never happened before. It happened now with the COVID vaccines, okay, which probably are irrelevant now. But so this is what the whole world started using from 2010 and onwards. Not really exact. Some countries, not here in this country, some countries not here in the US, they use PCV10. What is PCV10? So we have 10 serotypes, okay, and you conjugate them with the another autopathogen bacteria, non-typable Haemophilus influenza, okay, and together, okay, I think you get 3 or 4 shots, okay, and they were supposed to be, it was also supposed to be very efficient. The truth, when you do all those post-marketing studies, when they did head-to-head comparison, okay, it's probably both of them were, they gave the same results. Okay, so where are we now with PCV7 and PCV13? This is like a very recent meta-analysis from, it's going to be published actually next month, okay, in vaccine, okay? And as you can see, we still have, in some studies, almost 30% of ear cultures positive for strep pneumo. How could it be? Okay, we have now we stopped using PCV7. We are now 15 years after the PCV13 came out, and we still have 30% of ear cultures still positive with strep pneumo. Doesn't make sense, right? And on the other side, okay, and these are the strains that are now being, they are not included in the PCV. These are the strains that are now being isolated, about 20% of the cases. And on the other side, you see an increase in Haemophilus influenza and Moraxella catarrhalis cases. So there's like an interplay now, right, between strep pneumo. We thought we got rid of him, okay, but not anymore. And we have an increase in non-typable Haemophilus influenza cases. If I can comment on Moraxella, okay, I don't believe those numbers. I think that Moraxella catarrhalis is just an innocent bystander, okay? It does not do anything with otitis media. So people look at the numbers, okay, and we have now PCV15, okay? Not only that, we have PCV20, and not only that, we have even now PCV21. So the battle is not over, okay? And the new vaccines, so here's you have all the list of the serotypes, what's covered and not covered. And as you can see, these higher valent vaccines, okay, now they offer protections against more serotypes than what PCV and of course PCV13 and PCV7 they offered. Is this going to be the end? Probably no. So how did they decide should we use PCV15 or PCV20? They do not perform any clinical studies anymore. They use Markov decision models. What are these? Plain language, okay? Say now you immunize kids with PCV13. Let's see what happens if this is a theoretical model, okay? It's not in real life, okay? Let's what happens now if we start immunizing with PCV20? So you have all kind of calculations, and the bottom at the bottom line is it cost effective? Yes or no? And the numbers say yes. If you start with PCV15, okay, you see the how much cases you can spare with if you use PCV 15. This is PCV 15. This is the another name for it. You see how many cases can be averted, okay? And if you do with PCV 20, even more. So just by these sophisticated mathematical models, okay, they now started recommending on using those higher valent vaccines. What does the CDC says? You can do it both. Okay? There's no recommendation PCV14. I mean, there's no specific recommendation use this or that one. So here in this country, okay, you'll see now from September 2024, okay, kids being immunized either with PCV15 or PCV20. How do you decide? Money. In our country, we decided to immunize with PCV20, which is 5 times more expensive than the PCV15 and 10 times more expensive with the PCV13. We're not a rich country, not at all, but we decided if we'll invest, okay, in immunizing new kids, okay, with PCV20, we'll have the herd immunity effect and probably protect the whole population. By the way, you guys vaccinate here in a 3+1 schedule. We do only 2+1. Okay, so we save some more money. This is like 1, 2, 3, and this is the booster. So which one is better? This is for you guys, okay, to study, okay, and explore. So there are still no real-world post-marketing data available yet. Okay, so we still don't know if it was really more effective, the PCV15, 20 or PCV15 when you compare it. What about the flu, the influenza flu vaccines? The bottom line, it depends on the seasonal activity of influenza in that winter year. For example, back in 2009, there was the swine flu. Remember that? Okay, so if you were vaccinated against flu, okay, probably you had less otitis media episodes. But in a shallow season of flu, for example, during COVID, okay, we didn't have flu at that time. So there was no point in vaccinating against a flu if you wanted to protect yourself with otitis media. So this is in 2019, which was a regular season here in the United States, okay? So without immunization, you see how many cases of acute otitis media, about 8 million cases of kids that were not immunized with flu. But when you compare it with kids who were immunized against flu, only 2 million cases. So the difference is 6 million cases which could have been saved. Okay, so think about it when you tell your patient or you consult their parents, okay, and tell them, because sometimes they come to me and say, do you recommend getting the flu shots? And I tell them, listen, it all depends on the seasonal activity, and we cannot predict what's going to happen, right, in the next 2 or 3 months. But I showed them this slide, I showed them these numbers, okay? This was a regular flu season here in the United States, and look at the numbers here, and I am convinced, okay? But it's really up to them to decide. The latest Cochrane review, I'm sure you know what it means. It's about almost 10 years ago, and it says very moderate effect, okay? Only 4% reduction in AOM and 11% reduction in number of antibiotic prescriptions for acute otitis media. But again, that was before COVID, and if somebody wants to join them because they're recruiting now co-authors, okay, for the Cochrane review to see what's going to be the next recommendation. What about vaccines against non-typable Haemophilus influenza and MCAT? The bottom line, we're not there. Okay, so in the mouse model, okay, they worked pretty well. Okay, but when it came to when they started immunizing humans and kids, okay, they were not effective at all. So actually, this whole okay, many people, they invested time and money, okay, in developing those effective vaccines, okay. In the mouse model, it worked wonderfully, but in the humans, so not at all. So they actually, I don't think people still work on it. Maybe I'm wrong. What about the RSV vaccine? So this is the RSV, okay, and remember this nice tree here. That's the F protein. It's a very important protein on the surface of the RSV. So this is how it looks like. And the F protein was the new target for a vaccine. So it's actually a surface glycoprotein. It was essential for infecting host cells by fusing the viral and cellular membranes. I'll show you in a sec. And it, due to high conservation and role of eliciting neutralizing antibody, it is the primary target for RSV vaccines and therapeutic monoclonal antibodies. So we have two commercial RSV vaccines. I'm not sure how to pronounce this and that one, okay? And you see they're all brand new, okay? So this one's from 2025, okay? And you give it, and I'll show you for a second what happens. There is a big confusion, okay? To whom should we give the RSV vaccine? What kind of vaccine and when? And it varies according to local recommendations. In many countries, for example, in France, I'll show you a study from them. Okay, they gave a single dose of that vaccine. That was a monoclonal antibody. Okay, in for kids, and or they gave this vaccine. Okay, or they give a different vaccine. Okay, to the mother. So you can give either antibodies, monoclonal antibodies for infants, or immunize pregnant women. And that's actually the big numbers. These are all pre-vaccine seasons of RSV and otitis media. So here's COVID. You see here there was not a lot of RSV activity, but you see all the seasons look the same. This is when they started vaccinating against RSV to both pregnant women or gave antibodies to newborns, and you can see a very nice reduction in otitis media cases. So the bottom line, it helps. Okay. So this is like they had like almost 70,000 cases, okay, of AOM, and the rate, okay, significantly decreased after RSV immunization implementation. So we will probably see more studies like that, okay, showing a promising reduction of AOA, acute otitis media, in the first year of life. Remember, RSV, okay, is really pathogenic in the first year of life. It causes bronchiolitis and so forth. What about new emerging bacteria? So we all know that we have strep pneumo, Moraxella, and non-typeable Haemophilus. They are the classic autopathogens. Sometimes you can consider Staph aureus, okay, or strep pyogenes. But when we started using, I'm not a microbiologist, but we started mass spectrometry, okay, about 20 years ago. Clinical labs do that, okay? I'm sure here too. This is the acronym, okay? We started getting all kind of bizarre results, right? Of bacteria we never heard of, right? In medical school, right? How do you even pronounce this one? This thing, okay? Acronomobacter, Xylocydins, or whatever, Serratia, and all that. Mind you, this is probably the most prevalent one, Turricella. And all kind of case reports came out during the years, and they showed that okay, we have an AON with this, and two cases with this. Okay, but what do you do with that? Okay, still unsure. I know. We just got published, okay, in a paper. We had 40 kids with these new bacteria, okay, and we showed that they have a more benign course of the disease. So they're probably just because the PCR is like very, very sensitive, okay? You now have results of that you wouldn't have if you just used, standard regular cultures. But let's see what happens in the future. Tools. Okay, so you know this, right? This is the handheld otoscope. Okay, you use it for years. The big problem, the biggest problem for beginner is if you have earwax, okay, and it's very hard to teach, okay, because I'm using the otoscope and I tell my resident, okay, come see, and this is AOM, and he says, well, okay, that's AOM, right? And it's very hard to teach, and it's very, very, very subjective, okay. So I'm not sure. But we're still using it, okay? So we have now new technologies, okay? And I'm not sure ENTs really use them, but primary care physicians and pediatricians across this country use them. So this is OCT. This is the otoscope that uses OCT, optical coherence tomography, okay, for AOM diagnosis. So this is me. This is my residence. This is like in a city near Chicago, okay? After we had a very long transatlantic flight, okay? And I had congestion. So this is my ear. So what we see here, seriously, so this is the tympanic membrane. This is the external ear canal, you see here in black, but this is fluid in the middle ear. Now we can all see, okay, and we're convinced, right? Because if it was if my I didn't suffer any fluid in my ear, so it would be probably black, like black here, typically right, and black here. But you see all those white dots, and when you start doing the tomography, I'm sorry, the acoustic imitance, okay, and tomography. So this is the depth. So this is like the external ear canal. Here you have the tympanic membrane, and here you have the infusion. It's me, right? It's my ears, okay? Now, I don't know if you have you seen it before? I won't tell you the name of the that tool, okay? But what primary care physicians do, so they scope the ear. Everybody can see this is the tympanic membrane, maybe some fluid here, okay? And at the end, you can even, send the pictures to the electronic record, the EMR, okay? And it tells you right away, okay, if it was normal appearing tympanic membrane, was it acute otitis media or just MEE? Okay, they have CPT codes, and it's very popular, I have to tell you. AI, okay, everybody wants AI, you too, right? So, how AI can help you diagnosing otitis? I'll show you in a second. You use an endoscope, not the otoscope. You use a very thin endoscope into the middle ear, into the external ear canal, okay? And we capture the image. But before that, I have to train the software. So I'm using my own images and images I found on the internet, okay, on the web, okay, of normal appearing tympanic membrane. Here you have perforation, here you have effusion, here you have cholesteatoma, and here you have cases of meningitis. And at the end of the day, I teach the software what's normal and what's abnormal. It's called the rule 80-20. 80% of my images, this is for training purposes, and 20% of the remaining 20% of my images are for testing the machine. And who do you think is better, the human eye, the otologist, or the machine? Of course, the machine. How does it work? It's very complicated, but at the end of the day, they capture the image, okay? They reduce all those the color, okay? They use all kind of networks, and at the end of the day, okay, the software tells you what's the probability that the picture you just took to be normal, AOM, OME, or not, or CSL, CSL, okay, or not, sometimes not sure. This is how it looks like in real life. Okay, this is like a model that we used a few years ago. Okay, we're not doing it anymore. We use so you take a picture of the tympanic membrane. It goes to your cell phone. Okay, and from there, okay, wireless, it goes to the computer. These are pictures from a paper from China. So we teach the software. This is normal. This is OME, and this is AOM. we create heat maps. If it's red, it's hot. If it's blue, it's cold. Okay, and then we do like reverse engineering. Okay, and then we show them we show the machine. What do you think it's that? And they'll tell you in an accuracy of more than 95% that this is AOM and this is DOMA and so forth. Numerous papers, okay, have been published about that topic, okay. And is it already in use? The answer is yes, okay. This is a paper from JAMA Pediatrics, not long ago, okay, from 2024. And this is actually how they are using now their own automated classifiers to diagnose AOM in their own facilities, not only in the clinics, but also in the hospital, ED, and so forth. If you want, you can read it. The end of the day, okay, that the accuracy of their model was about 94%. When the human eye, when the otoscopist, okay, were asked, what do you think? Okay, their accuracy was about 80 to 85%. So their model was probably much better, okay, and they are still using it, okay. The last topic, it would be about new drugs. So you all know that the guidelines, okay, they endorse only oral antibiotic therapy. That's it, okay? Of course, painkillers, Tylenol, that's for sure, okay? But what about if you have a case of AOM and you decide that you want to start treating with antibiotics? And you can see here from the table here, only oral antibiotics, okay, are encouraged. Okay, you have amoxicillin, you have, okay, all these antibiotics. But of course, when you prescribe oral antibiotics to young kids, okay, they are associated with side effects. Sometimes the parents will be shy, okay, won't tell you about it, okay, diaper rash, okay, gastroenteritis, and so forth. So we're trying to restrict the use of oral antibiotics, okay, for acute otitis media cases where you really think you need to treat with antibiotics. And how do we do that? First of all, we have the topical antibiotic drops, okay, are out there anyway, okay. They are, at least where I come from, okay, I don't use them, okay. And why is that? The tympanic membrane is very thick. So the chances that these drops will actually go into the middle ear are very, very low. So why don't they just don't work? Okay, they sometimes you have a wax, okay, wrong pathogen, no infection, poor technique. It's very hard, to apply the drops to a young kid. And the problem is the tympanic membrane because it's very, very thick when you have acute otitis media. These are the layers of the tympanic membrane, and when you have a condition of acute otitis media, the thickness is about 3 or 4 times bigger, okay, than the normal size. So how do we overcome this barrier? First, they tried a thermosensitive cyprofloxacin gel. The idea was you put the gel because there's infection, so probably there's fever, right? The gel melts, okay, and you can see they showed nice accumulation, okay, of the gel inside the middle ear. The problem was the price, okay. Who will pay? It was not covered by the insurance, the insurance, and who would pay $300, okay, for a 10 cc gel? And then they came up with another solution. It will also fail. They tried to develop sustained release ciprofloxacin drops. So you apply the drops once a day, okay? And as time goes by, okay, the concentration of the antibiotic, okay, within the external ear canal, and according to them, they also measured it within the middle ear, okay, it just increased, okay, and it killed the bacteria there. It also failed because they were never able to show that these are real numbers, okay? So they had even to retract this paper. But what's next? This is the probably the work of the life of the San Diego group. So here you have the drug. Here you have the tympanic membrane. How do you transport them? Okay, from the outer ear canal to the middle ear, you use bacteriophage. The bacteriophage, what they do is active transport across the tympanic membrane. They have very, very nice results. And if they are, even if it's true, maybe we can use these drops, okay, with this special transport system, okay, and give drops to ear infections instead of oral antibiotics. You see, they try it, they have very nice concentration within the middle ear. They even try ciprofloxacin and ceftriaxone. We cannot administer ceftriaxone orally. So they have very nice results. Okay, is it still in use? Is it in use? Not yet. Okay, but from what I heard, they already have a patent. Okay, so maybe they are close to the market. So maybe you'll see them, like in 5 years from now. Stop using oral antibiotics and use those special eardrops. Okay, and this is probably the last slide. Okay, you go to Europe, you go to Italy. Maybe some of you have been there. You go to any pharmacy, you buy this thing for €5. It's about like $6. Okay, and this is called rhinogermina. What is rhinogermina? It's a dead Strep salivarius K12. So this is a non-pathogenic bacteria, and it's dead. Okay, you spray it into the nose, and what it causes, it binds the receptors of the other autopathogens. So when you have a kid, you spray it before winter begins. Okay, so the back of the nose, the nasopharynx, okay, it's all now obstructed with this non-pathogenic bacteria. And now when strep pneumo come and Haemophilus or Moraxilla come, they don't have any receptors to bind to. And this is probably an elegant way to avoid otitis media episodes. Why we don't see it in other countries? Because the evidence is very low, probably, and it's very hard to show one-to-one association between the use of this nasal spray and the reduction in the number of AOM episodes. That's it. If you have any question, you can email me or ask me now. And thank you for your attention. Yeah.
That's really nice. Do you know if people are using bacteriophages to kill the bacteria or just as a delivery
Just as a delivery.
mechanism? Yeah,
Yeah.
because
Yeah.
the
It
killing
has
of
to
great
be-
bacteria is so strange, so
Yeah.
they put the delivery mechanism.
Yeah, just from the outer world to the inner world.
Yeah.
Okay.
Yeah.
That's it. All right. Thanks. Oh, there was another question.
That was my question. I was just envisioning it not being very useful in like the bacteriophage therapy, at least in acute infections, unless they're like complicated acute infections, which you actually know the strain.
Yeah. Well, there's a difference between, no offense, okay, the mouse model, okay, and the real life, okay. What works for the mouse, okay, probably won't. Maybe yes, maybe no. Okay, will work in the human being. So they actually did. They're already in their phase 2. Okay, you know what a phase 2, right? Trial. Okay, so they were able to show that it was safe. Okay, in human beings. Okay, and now going to their the phase 3. Okay, to see that it's effective. Okay, but probably from what I know and from what I've heard, you probably see these drops, okay, in the very near future, okay, not 20 years from now, maybe in like 5 years from now, okay.
Those kids that had that kind of grew those, at least they were identified on multi-toff, these very obscure species. They had like over clinical evidence of otitis media, like on their exams, or these were kids that like had equivocal findings of.
No, they had otitis.
Okay.
They had otitis. I know that you don't do myrigotomy, right, anymore, you know, because probably the only place here in the U.S. is in Rochester, New York, right? We talked about it, but we do a lot of myrigotomy. If you have a kid, you gave him, I mean, not you, right? The primary doctor, you gave them first amoxicillin. It didn't work, so he switched to augmentin. Okay, it didn't work, so it's a treatment failure case, right? Now what? Now what will you do? What do you do now? I tend to just to sedate him, okay, not like with tubes or mask, okay, just sedate some propofol IV. I do the myringotomy, I drain the ear, I have a culture, and then I see those pathogens now. Now what I do with them, okay? So the bottom line, probably I won't change anything, okay? If they fail after augmentin or cefuroxime, probably they need some IV or IM, okay? Third line antibiotics. But what happens if they were treated just you got this air culture, okay, like from other EA, okay, so it was spontaneous or correct, so what do you do now with it? Okay, so we're still not sure, okay, probably this is probably okay, don't take me to court afterwards, okay, but probably just continue with the guidelines, okay, you do have your first line, second line, third line, and so forth. Don't switch to, you don't have to panic, say, oh, I have Tricella, now I'm going to give him IV or IM, okay? Just stick to the guidelines.
Yeah, I think a lot of times people do just as third line go to ceftriaxone before we do a myrigotomy. Are those bacteria susceptible to ceftriaxone?
They don't, when you have that kind of bacteria, they don't even test for antibiotics. You just get the result. You have Tricella, now deal with it. No, seriously.
So in those cases, were they like passenger organisms? Like were there other primary like was a streptococcal species identified as well?
No. That was the only pathogen that was identified. Now what do you do with that?
I guess my other question is, because when I irrigate the middle ear, I absolutely get external ear canal irrigation
Yeah.
also. Do you think that it could be?
Listen, you have to ask the authors, okay,
Yeah.
of these papers. But from what we do, I usually sterilize the external ear canal. So it's not like a saprophyte of the external ear, okay. So it has to be it comes from the embryolare. Okay, so you have some ideas for research, okay? Good luck with that. Right. Thanks for the attention and again for the invitation.
Thank you.